Hundreds of thousands of people in the U.S. die from medical errors every year. It's the third leading cause of death in the United States, right behind heart disease and cancer. In today's episode, we'll uncover shocking cases of medical negligence, a 9-year-old girl whose deadly infection was dismissed as mere anxiety, a patient who underwent cardiac surgery meant for someone else, and other horrifying instances where simple mistakes turned fatal. These aren't rare anomalies, they're tragic examples of how misdiagnosis, wrong patient identification, and communication breakdowns can have lethal consequences. This is the true tragedy of those who lost their lives because of medical errors. Willie King, wrong leg amputation. Imagine waking up from surgery to discover the doctor had amputated the wrong leg. This nightmare became reality for Willie King, a 51-year-old diabetic patient in Tampa, Florida. On February 20th, 1995, King went to University Community Hospital for a routine amputation of his diseased right foot. But when he woke up, he made a chilling discovery. The wrong leg was gone. How could such a catastrophic error occur? First, a scheduling error. The operating room schedule listed the wrong leg for amputation. Second, inadequate verification. The nurse prepped the wrong leg based on incorrect paperwork. Third, visual confusion. Both of King's feet were in poor condition due to diabetes, making it less obvious which one was scheduled for amputation. But here's where it gets even more disturbing. When the mistake was realized, there was an attempt to cover it up. The surgeon and someone from the hospital's risk management tried to convince King that the amputation of his left foot was necessary. For 2 weeks, the hospital avoided discussing the surgery. No one came to examine King's right leg or discuss his future care. Shockingly, King's case wasn't isolated. Within a month, the same hospital was involved in 3 other major medical errors, including operating on the wrong knee and partially sterilizing a woman without consent. These incidents highlight the critical importance of proper verification procedures and open communication in healthcare. They also reveal how easily errors can compound when systems fail and transparency is lacking. Sherman Seymour, awake during a surgery. Imagine going to the hospital for a routine surgery, but when the surgery starts, you are feeling every incision, every cut of the scalpel, but unable to move or scream. This nightmare became reality for Sherman Seymour, a 73-year-old Baptist minister from Beckley, West Virginia. In January 2006, Seymour underwent exploratory surgery for abdominal pain, but what should have been routine turned horrific. The anesthesiologists, Dr. Bruce Cannon and nurse anesthetist Larry Roop, administered paralyzing drugs but forgot the crucial step, giving Seymour general anesthesia. For 16 agonizing minutes, Seymour lay fully conscious, feeling everything but paralyzed and unable to alert anyone. How could such a catastrophic error occur? Firstly, human error. In the complexity of pre-surgery preparations, the anesthesiologists simply failed to turn on the anesthesia. Secondly, inadequate double-checking. Proper protocols require multiple verifications, which clearly didn't happen here. Thirdly, possible equipment issues. While not the case here, faulty machines can sometimes fail to deliver the correct dosage. When the team finally realized their mistake, they made another egregious error. They tried to cover it up. They administered an amnesia-inducing drug, hoping Seymour wouldn't remember the traumatic experience. They never informed him or his family about what truly happened. The consequences were devastating. In the following weeks, Seymour developed severe PTSD, insomnia, and an overwhelming fear of being buried alive. Tragically, just 2 weeks after the surgery, he took his own life. But here's the terrifying part. Seymour's case isn't isolated. Studies show anesthesia awareness occurs in about 1 or 2 out of every 1,000 surgeries under general anesthesia. Other patients have reported similar experiences, some with equally tragic outcomes. While medical professionals are working to prevent these incidents, the risk remains. Seymour's story serves as a chilling reminder of what can go wrong in the operating room and the devastating impact of medical errors and cover-ups. Before your next surgery, remember Sherman Seymour. Ask questions, understand the risks, and don't be afraid to speak up. Your life could depend on it. Alyssa, wrong diagnosis. In 2007, what started as a routine hospital admission in Denver turned into every parent's worst nightmare. Alyssa, a vibrant young girl who loved soccer and art, was diagnosed with leukemia. But it wasn't the cancer that would ultimately claim her life, it was a devastating chain of events triggered by a single careless label. On her very first day in the hospital, a second-year resident who would only see her once made a fateful decision. She labeled Alyssa as anxious in her medical chart. This seemingly innocent notation would cast a dark shadow over all of Alyssa's subsequent care, creating a dangerous bias that blinded the medical team to the true nature of her deteriorating condition. Initially, Alyssa responded well to treatment, but 7 days into her hospital stay, something changed dramatically. She began experiencing severe abdominal pain, and her behavior shifted noticeably. There were critical warning signs that something was terribly wrong. However, because of that initial anxious label, these symptoms were fatally misinterpreted. The medical team, anchored to this preconceived notion of anxiety, failed to look beyond it. When Alyssa's condition worsened, they prescribed Ativan, an anti-anxiety medication, instead of conducting a thorough investigation. This cognitive bias, known as diagnostic anchoring, would prove to be catastrophic. What the team failed to recognize, blinded by their initial assessment, was that Alyssa had contracted Clostridium difficile, a severe hospital-acquired infection. As hours ticked by, her condition deteriorated rapidly. Her blood pressure plummeted, her pulse raced, and she required oxygen. These were classic signs of sepsis, but the medical team remained fixated on the anxiety diagnosis, unable to see past that first label. Despite her mother's desperate attempts to convince the staff that this was more than anxiety, the critical lab results that could have saved Alyssa's life went unnoticed. This tragic oversight, known as a failure to rescue, meant that by the time the true nature of Alyssa's condition was discovered, it was too late. Just 10 days after her initial admission, Alyssa Hilgar passed away, not from leukemia, not from anxiety, but from a preventable hospital-acquired infection and a series of medical oversights that stemmed from a single misapplied label. This case starkly illustrates how a simple label, once applied, can create a dangerous tunnel vision in medical care. Today, Alyssa's mother, Carol Hilgar, travels the country sharing her daughter's story, warning medical professionals about the deadly consequences of diagnostic anchoring and the danger of letting initial impressions cloud clinical judgment. Medical errors remain the third leading cause of death in the United States, and cases like Alyssa's show how something as simple as an unwarranted label can set in motion a tragic chain of events. Joan Morris, wrong surgery. In a respected teaching hospital, 67-year-old Joan Morris was admitted for a simple cerebral angiography following a head injury. The procedure itself went smoothly, and she was scheduled for discharge the following day. What happened next would expose frightening flaws in hospital safety protocols. Through a devastating series of miscommunications, Joan Morris was mistaken for another patient, Jane Morrison, who was scheduled for an invasive cardiac procedure. Despite having no cardiac issues and being cleared for discharge, Morris was inexplicably transported to the cardiac electrophysiology lab. The sequence of errors that followed is nothing short of staggering. Even as Morris explicitly stated her opposition to any additional procedures, the medical staff continued their preparations. The attending physician failed to recognize that this wasn't the same patient he had consulted with the previous evening. More alarmingly, no one questioned the complete absence of proper cardiac procedure consent forms in her file. Perhaps most disturbing was how many opportunities to prevent this error were missed. When a neurosurgery resident discovered his patient had been taken to surgery, he questioned it but ultimately walked away, assuming there must have been a change in medical orders he wasn't aware of. Multiple staff members raised questions about the patient mix-up, yet none followed through to confirm the patient's identity. The horror of this situation reached its peak when the surgical team had already begun the procedure. It wasn't until an interventional radiology attending physician called to inquire about Morris's whereabouts that the terrible truth emerged, but not before an initial incision had already been made on an innocent woman who never needed cardiac surgery in the first place. This case brutally exposed the dangers of automated responses and assumptions in medical care. In a teaching hospital, where the highest standards of care should be maintained, multiple safety protocols failed catastrophically. The power of assumption and the breakdown of communication nearly cost Joan Morris her life. Jessica Santillan, Wrong blood type. The story of Jessica Sanon stands as one of the most shocking examples of how a simple oversight can lead to catastrophic consequences in organ transplantation. In 2003, this 17-year-old Mexican girl's case would expose dangerous flaws in transplant protocols at one of America's most prestigious medical institutions. Jessica arrived at Duke University Medical Center with hope in her heart. Suffering from a severe cardiac condition, she desperately needed a heart and lung transplant. When the call came that organs were available, it seemed like a miracle. However, this miracle would quickly turn into a nightmare. In a devastating oversight that would shake the medical community, the transplant team failed to perform one of the most basic medical checks: blood type compatibility. Jessica, with type O positive blood, received organs from a type A donor. It was a fatal mistake that wasn't discovered until the surgery was ending. The consequences were immediate and severe. Her body violently rejected the incompatible organs, triggering a cascade of catastrophic reactions. Despite desperate attempts to save her through immunosuppressant drugs and plasmapheresis, Jessica's condition deteriorated rapidly. Her new organs began to fail, and she suffered multiple seizures. In a last-ditch effort to save her life, doctors performed a second transplant with compatible organs 2 weeks later. But by then, it was too late. The damage from the first transplant had been too severe, causing irreversible brain damage. Jessica Sanon was declared brain dead on February 21, 2003. What makes this case particularly tragic is how easily preventable it was. 2 separate safety checks that should have caught this error failed completely. The surgeon never verified the blood type compatibility, assuming it had been checked, and the donor agency never confirmed it either. This catastrophic breakdown in communication and verification protocols cost a young girl her life. In the aftermath, Jessica's family had to fight for accountability. The hospital initially tried to downplay the gravity of their error, particularly challenging for the Spanish-speaking family who barely understood English. In 2004, Duke University Hospital reached a settlement with the Sanon family, though the details remained confidential. While the settlement proved some measure of justice, it couldn't bring back the young life lost to this preventable error. This was the true tragedy of those who lost their lives because of medical error. May their souls rest in peace.